Good morning. Nice meeting you. I am Francis Lee from New York City. I practice in Manhattan as well as New Jersey. And I belong to Columbia University, although I love this campus better. This is really a beautiful place. And I have a two training, like Dr. Stanton. I did my pediatric orthopedic training as well as adult pediatric oncology. And I do see both benign and malignant tumors. And although I'm a surgeon, but I love bone biology. So as a result, I do some NIH-funded bone biology research. And I have a very strong interest in the mechanism how the bone is dissolved. So it's a very difficult question, but I'm trying hard. So today, my job is actually to teach all of you, actually sitting in the front, to become not a doctor, but at least a healthcare provider or semi-professional for your friends. So I'll talk about the bone and how to read X-rays and how to actually see some pathology slides. And I'll talk about why bone is weak. And then lastly, I'll talk about some orthopedic care. So bone, as you know, it's very random terminology, and we just divide into cortical bone, which is the shell. It's the shell. It's more dense and it's more stiff. The second part is the bone in the middle over here called trabecular bone, and it looks like a sponge bar. So this is the histology of cortical bone. This is very dense, as you see, and the bone has some kind of a canal. It's like electric wire that supplies nutrition. And on the surface of a bone, there's a thin membrane called periosteum, and it's really amazing. It has lots of mesenchymal cells, and when the bone breaks, they make lots of callus to strengthen the weakened bone. And if we cut the bone in this section and look on the microscope, we see this kind of cells. It looks like a spider, right? And these cells are called osteocytes, meaning the principal resident cells of bone. And as a matter of fact, these osteocytes are the master regulators of bone biology. They make bone and they send a signal to dissolve bone. And they are connected by this kind of wire. And this is called canalicular system. And this is the actually Facebook and website, Twitter for the bone cells. They communicate so well. So if I touch the bone here, the cells on the other side get the message within really less than 1 second. And the other cells are called osteoblasts. They line the bone in the central part of the bone. So bone cells have osteocytes and osteoblasts. Let's look at the trabecular bone. So this is again the cross section of a bone. You can see the outer shell called cortical bone, and this is the inside. It looks like a real sponge. And if you look on the this bone on the microscope, you can see bone marrow. As you know, bone marrow has lots of fat, and the bone has lining cells called osteoblasts. And again, in the middle of the bone, they look very lonely, but again, I showed you they are communicating each other very in a delicate way, and these are the osteocytes. So you talk about osteoporosis all the time, and in fibrous dysplasia, in a sense, you have some kind of localized osteopenia. So this is the normal bone, and this is actually bone from osteoporosis patients. And you see that the bone density is very low compared to the normal bone. At the same time, they lose connectivity. Normally, bones are so really interconnected well, but even though sometimes you may have the same bone density, but if they are not connected, the bone is actually mechanically weak. In body, the cortical bone is more dominant. You have more cortical bone. However, the trabecular bone has more surface area, and that has more metabolic activity, such as calcium exchange, etc. And what is bone made of? About 80% is calcium. So we have chalk here. The same material, calcium phosphorus. And this bone is very dense. This chalk is very dense again, but it breaks very easily because this does not have matrix. Matrix means like fibers. So imagine if you can put a lot of fibers inside this chalk, this can be actually much stronger. So bone should have normal components, both calcium components as well as protein components. When people talk about osteoporosis and normal bone, very often people do not know actually what kind of changes happen in the bones from patients with fibrous dysplasia. This is a little bit complicated, but Dr. Collins mentioned that some of you may have some endocrinopathy, such as thyroid, Cushing syndrome, etc. And the bone is actually not quiet. We are talking to each other as well as talking to other organs, such as pituitary gland, thyroid, kidney, intestine, etc. So this is the understanding of bone biology as of today, but I'm sure it's going to evolve. Now it's going to be a little bit complicated, but I will explain in a very simple way. So I just talk about osteoblast. They lines the inside of the trabecular bone as well as cortical bone. The function is they make bone. They make more bone. The second is the osteocytes, which live in the bone condominium. Okay, they stay inside, but they talk to each other through their system called the canaliculum. And these osteocytes and osteoblasts make a protein called rank-ligand. Rank-ligand then talk to monocytes, meaning the cells in the bone marrow. They sometimes migrate to the bone surface. Then they make this kind of giant spaceship-like cells called osteoclasts. And these osteoclasts, the primary function is they dissolve bone. So why am I showing these slides? And this is the future treatment options. For example, we can block this rank-ligand. Then what happens? These monster cells cannot be formed. Therefore, we can preserve the bone better. And the medicine is already FDA approved, and we are using this medicine for multiple myeloma, osteoporosis, and other cancers. However, they have some side effects as well. In terms of sclerostin, that's made by osteocytes. They talk to osteoblasts, hey, you guys not make more bone. I already have enough. So actually, company is making drug called anti-sclerostin antibody, so that there will be no inhibition to osteoblast. As a result, osteoblasts make more bone. And now, phase 2 clinical trial is being done in Europe to treat osteoporosis. So now let's talk about how to read the X-rays, so that when you talk to me maybe between talks, you can show me X-rays and you can discover your own X-rays. X-rays are like really pattern recognition. It doesn't really require specific knowledge once you know the anatomy and some of the pathology. So these days we talk about pattern recognition software. You walk through the gate and the CCD camera takes you a picture. They can identify you with a 99% accuracy. It's really very, very scary. Yeah. However, in medicine, okay, there was some contest. So radiologists read the CT scan of the lung, and then at the same time, computer read the CT scans. Because there are some anatomic and the physiology aspects, actually radiologist is the one. They are about accurate in 60 to 80% of the time, while computer alone was 21%. So I will show you what to look in X-rays. Very simple. So this is the X-ray of your knee bone. You can see the kneecap, and you can see the bone called the femur and tibia. You just look 4 things. Number 1, shape. So that means look at the normal skeleton, especially for you, skull bones, humerus, hip and pelvis, spine are very often affected. So just look at the shape. The second is the size, meaning compared to other side, whether it's symmetric or it's longer or shorter. The second is the density. Bone has this kind of calcium. If I put this in the X-ray machine, it looks like a white bar because it has lots of calcium. So density changes when this chalk loses about 30% of the calcium, then it looks dark, like over here. So that means if there's a lot of spotty changes, that means you already lost about 20 to 30% of the calcium content. And number 3, structural relationship, where the joint is aligned or dislocated. So again, very simple. Size, shape, density, and relationship. So can I try some case with you? No, I'm just joking. So these are actually cases of bone tumors. They are about common tumors, maybe 30 or 40 tumors, and they look sometimes very similar. This is the area of the nail, I'm sorry, with the femur lesion. Some part of the bone is missing, bone is very irregular. And among these, there is actually one fibrous dysplasia monastery tumor. And this really looks like a fibrous dysplasia, but again, this is a case of metastatic breast cancer patients. So that means X-rays are very non-specific. It's like a shadow, and the shadow only has a black color, and this shadow does not tell whether the actual object is, the color is red, yellow, or blue. But at least we have some sense. And this is why we take tissues and examine under microscope. That's called pathology. But very interestingly, this is a very commonality. Whenever you see this kind of big bone loss here, I'm too short, I jump. Oh, there, and here, and there. There's one commonality, osteoclast. Remember the monster cells I mentioned? So all this bone destruction is mediated by monster cells called osteoclasts. And this is the case of fibrous dysplasia, monastery. Again, you see some bone loss, but you have some little bit of white chalk-like material. And all days, people used to call that as ground glass appearance. And you can see the bone here. And at the same time, you see some osteoclastic activity. So now you're an expert. So this is the X-ray of fibrous dysplasia patients. What do you see here? Size. We don't have the other side, but size is smaller. Shape, is this normal? Just comparing to the normal hip X-rays. Yeah, there's a lot of angulation. Number 3, what is the density? Is the density very even? Okay, let's look at the cortical bone. Look at the cortical bone here. It should be very clean line. But look at this. There's a lot of scalloping. Something is trying to eat. Yeah, those guys are osteoclasts. What about trabecular bone? It's very irregular. So density is very irregular, and the cortex is very thin, and the bone is deformed. So this is a classical case of fibrous dysplasia. Now, let's look at the pathology of fibrous dysplasia bones. This is a normal bone histology. And this is bone from fibrous dysplasia patients. What are the difference? This is really common sense, again, pattern recognition skills. Number 1, the bone is very dense, and you can see this kind of line. It's very regular in highly ordering fashion. In fibrous dysplasia, bone is more likely in haphazard fashion. This is more, has a structure, but this has a very irregular shape, and the normal bone marrow can see the fat and the bone marrow cells are replaced by fibrous-like cells. And in normal bone, you can see osteoblast. Here, osteoblast-like cells are there, but it's not exactly same. But osteocytes seems to be quite similar in both cases. So this is a high-power view. Again, bone, see this kind of well-structured layers, and you don't see this in fibrous dysplasia bone. What does that mean? You may have actually more bone in the area of fibrous dysplasia, but because of this lack of structure, bone can be weak, just like this. Even though you may have more bone, bone can be weak because there is no structural arrangement. Another high power view. Can you recognize these cells, monster cells? They are eating bone. This is why X-rays show like a scalloping or apple core-like appearance. So again, this is a comparison between normal and fibrous dysplasia. You can see a striking difference. So we need some research how we can actually reprogram this disordered cells so that the cells here somehow they make a bone in a more structural manner. I mean, this is really fascinating research topic, and I wish I can get engaged in the research in the future. And now let's talk about some mechanical aspects. Why bone is weak? And to my knowledge, I don't think there has been really nice, simple scientific study on the mechanical properties of fibrous dysplasia bone and the normal bone. So if you get X-rays, you can see the shadow very well, but if you can get CT scan, you can see actually three-dimensional structure of both cortical bone as well as trabecular bone. How do we measure bone strength? There are two ways. One is getting CT scan, then somehow engineers can figure out how to calculate the mechanical properties, meaning whether bone is stiff or bone is strong. That's the first thing. And the second is biomechanical test, meaning sometimes actually we test the bone by applying the force. But this kind of thing cannot be done in real patients. So I think this may be the way, or if we can obtain some bones from a museum or some other sources, at least we can calculate. So that means like this, when a patient is 5 years old, we obtain CT scan, then we can calculate the risk, whether the bone is strong enough to sustain the body weight and it will remain straight or will change into crooked position. I think this could be one of the future research topics, but I'm not sure whether there's any value of doing such research at the present time. So now, let me share actually one case with you, only one case, just to explain orthopedic intervention in patients with fibrous dysplasia. And as a matter of fact, she's in the audience, and she really graciously agreed to share her clinical information. So she came to see me at age 20. I don't know how old she is now. I think she's over 30 now. And she complained of left hip pain, and she had a severe limb length discrepancy because it's unilateral involvement, meaning only one side is involved. And she had a limping gait because one leg is extremely short, about 25, almost 1 foot difference. And also, the pain on the left hip really bothered her to walk, so she almost walked like this. But basically, technically, she was not able to put any weight. And she had a surgery in Philadelphia when she was a child. And she had actually had several surgeries, as Dr. Stephan mentioned. And she had hit some severe high level of pain medication to control pain once in a while. And her laboratory test showed somehow alkaline phosphatase was elevated. I do not know the significance of alkaline phosphatase activity in fibrous dysplasia patients. So anyway, this was her X-ray. So let's talk about size, shape, density, and the joint relationship. Is this smaller than this side? How many of you think, yes, it's small? Good. Yeah, this is smaller. And the shape, yeah, you can see actually the hip bone there, and it's very, very different. It's crooked, short, and there's some loss of a bone between the bone and the remaining part of the femur. Density, she has a loss of bone density both in cortical bone as well as trabecular bone. You can see a lot of patch of dark areas in this dense trabecular bone region. And this is previous surgery. That means I think the previous surgery probably worked very well for the first several years, but she developed gradual deformity that led to the fracture of the femoral neck. That means she cannot put any weight. And you may ask me, what happens if the bone is gone? And who cares? I mean, I don't have any pain. How does it affect my function? And I'll show you some example. And this was her bone scan, again showing typical involvement in the femur, tibia, foot, and the humerus, and somehow only one side of the skull bone. And I talked to her, and I said, you know, fibrous dysplasia patients usually do not require surgery. We are not fixing the X-rays. We are not fixing the deformity. However, if you have some functional issues because of pain or severe deformity or severe limb length discrepancy, I may take chances because results are not always great. As a surgeon, good results means successful results for longer than 10 or 20 years. If I revise surgery in 1 or 2 years, from our ends, it's not really satisfactory. So I analyzed it carefully, and she had 3 issues. One is painful left hip, limb length discrepancy, and limb deformity. So this is her hip X-ray, and this is the hip. The ball should be higher than this tip here. This is called the trochanter. The ball should be higher than this, so that the muscle over here can pull the hip. By doing that, you can bring the leg to the outside, or when you're standing with one leg, this muscle can support your entire body. However, if this ball goes below this, even though you pull very hard from here, it's not mechanically efficient. It's like a door handle. Why door handle? When you open the door, you push here, and you never push from here. It's very, very difficult. It's the same principle. So the goal of hip surgery is somehow restore this femoral neck and the shaft end. So in this case, what we did was that she had a severe varus, so we had to take some wedge of the bone out to straighten the proximal femur. And she had a femoral neck fracture, so we did hemiarthroplasty. And in her case, we added some topical bisphosphonate solution. And the bisphosphonate is known to kill the monster cells, so that we can hopefully preserve the bone a little bit better. And this is after her first surgery. And the problem is that now I fixed the hip, and you can see that this ball is way above this trochanter. That means I restored the normal hip anatomy and the biomechanics. Now she had 2 different issues. One is she has about 10 to 15 centimeter limb length discrepancy, and as a result, she has been walking with the tip toes. And when you walk with your tip toes for several years, you develop Achilles tendon contracture and ankle contracture. So what I did was that I lengthened the tibia and also I did Achilles tendon release. So lengthening is not usually done in fibrous dysplasia. However, in her case, it was unilateral, and she needed it for her professional life and also hopefully the better function of life. So how do we do bone lengthening? Basically, we divide the bone and we lengthen 1 millimeter per day. Then I was able to lengthen about almost 3 inches. Let me see. I'm pretty short. From here to there, this is almost 3 inch lengthening. And thankfully, she has not developed any neurovascular contracture. But look at this ankle. You can see that ankle is turning down. So I did here for the lengthening when I did insertion of the screws for the nail. So this is after the lengthening. You can see more bone formation here, and she restored almost normal bone. And very intriguingly, I think the normal new bone, even after her birth, has fibrous dysplasia because again it's coming from the same mesenchymal stem cells. So this is a before and after. Now you can see ankle level is almost even, about 1.5 or 2 inches short. And she compensates better with the pelvic heel. And she's still using with cane. And she still has some occasional pain once in a while, suggesting ongoing stress or insufficiency fracture. Now we have some new technology. This is actually a case of other patients. But instead of doing two-stage lengthening procedure, actually we can lengthen the bone just by this spring nail that can elongate by itself when I apply magnetic force without making skin incisions. So I think there may be some role for lengthening in unilateral cases. So in summary, orthopedic treatment is not necessary in the beginning. We need more research, and we address only there's an issue of function, but at least the head is concerned, it's better to maintain or restore the biomechanical relationship of the femoral head and the femoral shaft. So I'll stop here, and I'll be available for any discussion. Thank you so much.